Mark Guida, DMD, PhD Birgit Ho GL, MD. Introduction. Recently, an international expert commission has redefined bruxism as repetitive jaw muscle activity characterized by clenching or grinding of the teeth and/or by bracing or thrusting of the mandible that can occur during wakefulness, i.e., awake bruxism, or during sleep, sleep bruxism. Awake bruxism is usually seen as a jaw-clenching habit that appears in response to stress and anxiety states, while sleep bruxism represents a sleep-related rhythmic masticatory activity generally associated with arousals from sleep. Both awake and sleep bruxism are sub-classified into either primary, not related to any other medical condition, or secondary, associated to neurological disorders or considered an adverse effect of drugs. Bruxism can lead to dental wear, jaw muscle pain and fatigue, and temporal headaches, and in some severe forms can compromise oral functions such as chewing, speaking, and swallowing. However, no direct relationship has been observed between the type of bruxism, the severity, and the presence of additional clinical signs and symptoms. In fact, it has been reported that patients with frequent sleep bruxism are less prone to complain about fatigue and pain in the masticatory muscles than the patients with fewer masticatory events per night. Awake bruxism is usually identified by the patient, but there are no objective methods that reliably quantify this behavior. In contrast, the American Academy of Sleep Disorders has proposed both clinical and PSG criteria for diagnosing sleep bruxism. These advances in its measurement have helped to launch several randomized clinical trials, RCT, for evaluating the effects of different therapies on reducing the masticatory activity during sleep. The aim of this article is to review the therapeutic approaches for treating bruxism and clarify the current evidence. Methods. A literature search was performed using Medline, PubMed database, combining the terms bruxism or teeth grinding or clenching and treatment is the first step in the research strategy. All abstracts in English were screened. We first selected RCT performed in adults older than 18 years with a clinical or PSG diagnosis of bruxism, awake bruxism and/or sleep bruxism, independently if they had or not comorbid sleep, neurological, or psychiatric disorders. Non-randomized comparative studies, pre-treatment post-treatment studies, cohort studies, and case reports were considered in case of scarce or lacking RCT. Bruxism. Effective management of primary awake bruxism is challenging. Since increased anxiety levels and somatization symptoms have been reported in these patients, interventions such as counseling about triggers, habits modification, relaxation therapy, or biofeedback have been suggested to be appropriate. However, no RCT exists to support these approaches. In contrast to awake bruxism, several RCT have been performed to investigate the efficacy of different treatments in the reduction of bruxism activity during sleep. Most of them showed heterogeneous results. The treatments evaluated are as follows: 1. Sleep hygiene measures combined with relaxation techniques, 2. Splint therapy, 3. Pharmacological therapy, and 4. Contingent electrical stimulation. Sleep hygiene measures combined with relaxation techniques. The treatment of sleep bruxism usually begins with counseling of the patient with regard to sleep hygiene. There is only one RCT that evaluated the effect of 4 weeks of sleep hygiene measures combined with relaxation techniques on sleep bruxism, as shown by PSG, but failed to find significant differences in comparison to baseline. Besides this negative result and the lack of evidence with other behavioral approaches, it is still reasonable to recommend good sleep hygiene in clinical practice, especially considering that alcohol, tobacco, and coffee consumption are risk factors for sleep bruxism and that sensitivity to stress is commonly reported by the patients. Splints have been considered as the first-line strategy for preventing dental grinding noise and tooth wear in primary sleep bruxism. However, its efficacy reducing the number of masticatory episodes per hour of sleep seems to be transient, with a maximal effect observed during the first 2 weeks, and returning to baseline after longer periods of use. Only one study have compared occlusal splints versus a medication doses gabapentin, and found that both treatments reduced similarly the muscle activity associated with sleep bruxism after 2 months of therapy. Albeit rare, occlusal splints may worsen respiration during sleep in patients with obstructive sleep apnea (OSA), and thus, special care should be taken when treating sleep bruxism in this population. In the absence of larger studies that confirm this adverse effect, a mandibular advancement device might be an alternative treatment in patients with concomitant OSA and sleep bruxism, because it decreases both the number of sleep respiratory events in OSA and the sleep-related masticatory activity in sleep bruxers. Again, to generalize this indication, more research needs to be done. Table 1. Primary sleep bruxism. Overview of randomized clinical trials. Splints therapy. The initial diagnosis of sleep bruxism is based on the diagnostic grading system proposed by Labozo et al. Possible sleep bruxism, based on questionnaires, are the anamnestic part of the clinical history. Probable sleep bruxism, based on questionnaire and clinical examination, and definitive sleep bruxism, based on questionnaires, clinical examination, and confirmed by PSG or portable EMG or audio-video recording. Duration makes reference to treatment duration. EMG electromyography, PSG polysomnography, RCT randomized clinical trials, N.S. Not significant a randomization. Citation, Dubé et al. Study type, crossover RCT. Group, 9 definitive sleep bruxism. Intervention, occlusal splint, palatal splint. Duration, 2 weeks. Results, both occlusal splints and palatal splints reduced rhythmic masticatory activity during the PSG. Citation, Van der Zog et al. Study type, parallel RCT. Group, 21 probable sleep bruxism. Intervention, occlusal splint palatal splint duration, 4 weeks. Results, neither occlusal splints nor palatal splints reduced rhythmic masticatory activity during the PSG. Citation, Harada et al. Study type, crossover RCT group, 16 probable sleep bruxism. Intervention, occlusal splint palatal splint. Duration, 6 weeks. Results, both occlusal splints and palatal splints reduced nocturnal masseter activity on portable EMG the night after the insertion of splints, but not after 2, 4, or 6 weeks of therapy. Citation, Landry et al. Study type, crossover RCT. Group, 14 definitive sleep bruxism. Intervention, occlusal splint mandibular advancement device in 3 grades of protrusion. No protrusion, at 40%, at 75%. Duration, irregular. Results, both occlusal splints and mandibular advancement devices reduced rhythmic masticatory activity during the PSG. Higher advancement with mandibular advancement devices was associated with larger decrease on rhythmic masticatory activity. Citation, Landry-Schonbeck et al. Study type, crossover RCT group, 12 definitive sleep bruxism. Intervention, occlusal splint mandibular advancement device in 2 grades of protrusion. At 25% at 75%. Duration, 2 weeks. Results, mandibular advancement devices reduced rhythmic masticatory activity during the PSG. Occlusal splint tended to reduce rhythmic masticatory activity during the PSG N.S. Citation, Arima et al. Study type, crossover RCT. Group, 11 possible sleep bruxism. Intervention, occlusal splint mandibular advancement device in neutral position, in 2 conditions. Not fix. Duration, 1 week. Results, both occlusal splints and mandibular advancement devices reduced nocturnal masseter EMG activity on portable EMG. No differences between devices. Citation, Madani et al. Study type, single blind, parallel RCT. Group, 20 definitive sleep bruxism. Intervention, occlusal splint gabapentin 300 mg. Duration, 8 weeks. Results, both occlusal splints and gabapentin reduced rhythmic masticatory activity during the PSG. Therapy. Muhammad et al. Reported the first RCT evaluating amitriptyline, used during 7 days, in a group of patients with sleep bruxism and temporomandibular disorder symptoms, and found no changes in pain reports and in the nocturnal masseteric muscle activities with the therapy. Labazo et al. Evaluated the acute effect of levodopa in 10 severe sleep bruxers and found a decrease in the number of sleep-related masticatory events in 7 of them when compared to placebo. However, given the unknown clinical relevance and the lack of further research supporting its use, levodopa is not considered as a treatment for sleep bruxism. Night treatment with clonidine, N. Alpha-2 adrenergic agonist used for treating hypertension, attention deficit hyperactivity disorder in children, and for acute alcohol or substance withdrawal syndrome, has demonstrated to reduce bruxism activity by 60%, but with significant adverse effects such as morning hypotension, REM sleep supras, Sion, and dry mouth. In patients with psychiatric and sleep comorbidities, the acute use of clonazepam has been reported to improve sleep bruxism activity together with the general quality of sleep, as suggested by Salatu et al. However, these results are based on single-blind non-randomized trials. To finally recommend both clonidine and clonazepam in the clinical routine, high-quality double-blinded RCT with larger sample size, different adjustable doses and larger duration, systematic assessment of adverse events, and perhaps also withdrawal studies are needed. Recently, some studies have evaluated the efficacy of botulinum toxin type A injections into the masticatory muscles for treating sleep bruxism. Found that the amplitude of the muscle contraction during bruxism events was reduced after 4 weeks of injection, but with no changes in the rhythm or number of bruxism episodes per hour of sleep. Lee et al. Reported similar results in an ambulatory EMG-based study over 8 to 12 weeks. After botulinum toxin injection, however, no differences were observed in the relief of teeth grinding sounds and morning jaw stiffness in comparison to saline injections at any time of the study. More RCT comparing the effect of botulinum toxin, saline injections, and dry needling are needed to clarify if botulinum toxin is useful in the management of sleep bruxism with and without orofacial pain. Citation: Muhammad et al. Study type: double-blind, crossover RCT. Group: 10 probable sleep bruxism. Intervention: amitriptyline 25 mg, placebo. Duration: 1 night. Result: amitriptyline did not reduce nocturnal mesenteric EMG activity on portable EMG. Citation: Labazo et al. Study type: double-blind, crossover, RCT. Group: 10 definitive sleep bruxism. Intervention: levodopa benserazide 1/25 of a milligram placebo. Duration: 1 night. Result: levodopa reduced rhythmic masticatory activity during the PSG in 7 of 10 patients. Citation: Levine et al. Study type: double-blind, crossover RCT. Group: 7 definitive sleep bruxism. Intervention: bromocriptine 7.5 mg, placebo. Duration: 2 weeks. Result: bromocriptine did not reduce rhythmic masticatory activity during the PSG. Citation: Wynn et al. Study type: crossover RCT. Group: a 25 definitive sleep bruxism. Intervention: Study 1 N equals 10 propranolol 120 mg, placebo. Study 2 N equals 16 clonidine 0.3 mg, placebo. Duration: 1 night. Result: propranolol did not reduce rhythmic masticatory activity during the PSG. Clonidine decreased rhythmic masticatory. Citation: Shim et al. Study type: randomized, parallel, before-after study. Group: a 20 probable sleep bruxism. Intervention: botulinum toxin type A in masseters, botulinum toxin type A in masseters plus temporalis. Duration: 4 weeks. Result: botulinum toxin type A did not reduce rhythmic masticatory activity during PSG, but decreased the strength of contraction in the injected muscles. No differences between injecting 2 masseters or 4 masseters plus temporalis muscles. 9 out of 20 patients reported decreased teeth grinding after the therapy. 50% reported improvement of morning jaw stiffness. Citation: Lee et al. Study type: double-blind, parallel, RCT. Group: a 12 possible sleep bruxism. Intervention: botulinum toxin type A, saline. Duration: 12 weeks. Result: botulinum toxin type A did not reduce nocturnal masticatory activity on portable EMG, but decreased the strength of contraction in the injected muscles. Both botulinum toxin and saline injections. Saline injections improved subjective symptoms of sleep bruxism. Stimulation. In the last years, contingent electrical stimulation, CES, has reappeared in an attempt to reduce the masticatory muscle activity associated to sleep bruxism. The rationale for CES consists in the inhibition of the masticatory muscles responsible of bruxism, applying a low-level electrical stimulation on the muscles when they become active, i.e. during the bruxism episode. 2 experimental studies have applied CES in patients with signs and symptoms of sleep bruxism and myofascial pain, and found a reduction of the EMG episodes per hour of sleep while using CES, but with no changes in pain and muscle tension scores. Raphael et al. Confirmed these results in a group of women with sleep bruxism and myofascial pain, but in addition showed that the efficacy of CES in reducing nocturnal bruxism events was confined to active periods and not after discontinuing the device. 43. Even if these results are promising, the unknown effect on tooth wear and the low impact on pain symptoms may limit the generalization of its use. Additional studies evaluating long-term treatment periods, the impact of contingent versus sustained electrical stimulation, and the combination with other therapies are still needed. Electrical stimulation. Citation: JDD et al. Study type: double-blind, parallel RCT. Group: 11 probable sleep bruxism with myofascial pain. Intervention: contingent electrical stimulation, placebo. Duration: 6 weeks. Results: contingent electrical stimulation reduced by 52% nocturnal temporalis muscle activity on portable EMG during active therapy. No changes in self-reported muscle pain and tenderness were observed. Citation: Conti et al. Study type: single-blind, parallel RCT. Group: 15 probable sleep bruxism with myofascial pain. Intervention: contingent electrical stimulation, placebo. Duration: 3 weeks. Results: contingent electrical stimulation reduced nocturnal temporalis muscle activity on portable EMG during active therapy. No changes were found in the placebo group. Contingent electrical stimulation did not influence perceived pressure pain thresholds or pain intensity. An acute onset of severe teeth grinding that occurs mainly during wakefulness and that cannot be prevented voluntarily should alert the clinician about the secondary etiology of bruxism. Moreover, it usually accompanies typical hallmarks of the underlying disease. For example, some patients with cranial and cervical dystonia show severe awake teeth grinding in combination with dystonic, dyskinetic movements in other parts of the face. In 2 patients with drug-resistant temporal lobe epilepsy, long-lasting teeth grinding episodes were the main features of the seizures, and usually preceded other typical signs such as the loss of consciousness in the limbs automatisms, and in 3 women suffering from Huntington's disease, Tan et al. Reported a persistent awake teeth grinding that worsened with the progression of the disease. The management of bruxism associated with neurological disorders focuses on improvement of chewing, speaking, swallowing, and feeding, which are severely compromised, and to relieve orofacial pain symptoms. However, no general rules can be applied because placebo-controlled studies are lacking, so a case-by-case approach is suggested. Conservative measures such as occlusal splints and the use of drugs for treating the underlying disease may help the patient to control his bruxism. For example, a single case report in a patient with multiple system atrophy and constant awake teeth grinding claimed a marked improvement 1 week after starting levodopa-carbidopa, while similar results were documented after using galantamine in a patient with Alzheimer's disease and awake bruxism. Injections of botulinum toxin in the masticatory muscles have been used in 2 case series of patients with severe bruxism associated with cranial dystonia and other movement disorders. In these studies, the therapy rendered the patients free of bruxism for up to 1 to 5 months and markedly improved pain reports and mandibular functions. Botulinum toxin was also effective in the resolution of bruxism that appeared during the recovering from coma in 4 patients with anoxic or traumatic brain injury. Finally, surgical treatment of temporal lobe epilepsy resolved the occurrence of ictal bruxism in 2 reported cases. It should be mentioned that intraoral devices should be used with caution in epilepsy. Patients' splints can break during seizures and obstruct the airway. A summary of the diseases with concomitant bruxism and the therapeutic approach is shown in Table 2. Monti et al. Characteristics of bruxism: teeth grinding occurring during wakefulness and less frequently during sleep that accompanied other dystonic, dyskinetic movements. In some cases, orofacial functions such speaking, chewing, feeding and swallowing were impaired. Treatment: botulinum toxin in masseters solely or in combination with temporalis and/or supraoid muscles. Outcome: reduction of bruxism. Duration of response: 13 to 19 weeks. Neurodegenerative disorders: Huntington's disease. Citation: Tan et al. Characteristics of bruxism: awake teeth grinding reported by patients and familiars that worsens with the evolution of the disease. Treatment: botulinum toxin in masseters. Outcome: reduction of bruxism. Duration of response 8 to 17 weeks. Neurodegenerative disorders: multiple system atrophy. Citation: Wally et al. Characteristics of bruxism: awake teeth grinding reported by patients and familiars, which disappeared during sleep. Treatment: levodopa-carbidopa. Outcome: attenuation of bruxism. Neurodegenerative disorders: Alzheimer's disease. Citation: Lai et al. Characteristics of bruxism: awake teeth grinding that disappeared while eating or speaking. Treatments: galantamine. Outcome: reduction of bruxism. Disorders: epilepsy. Citation: Guida et al. Maletti et al. Characteristics of bruxism: awake and sleep teeth grinding occurring during seizures, confirmed by video EEG. Treatments: temporal lobectomy. Outcomes: disappearance of bruxism, confirmed by PSG in. Disorders: anoxic traumatic brain injury. Citation: Van Zandijek et al. Ivanhoe et al. El Mehta et al. Characteristics of bruxism: sudden and continuous teeth grinding during the recovering of coma. Treatments: botulinum toxin type A. Outcomes: improvement of bruxism. Disorders: stroke. Citations: Tan et al. Yi et al. Characteristics of bruxism: acute onset of awake teeth grinding, which improved during sleep. Treatments: botulinum toxin type A metoclopramide. Outcomes: improvement of bruxism. EEG, electroencephalography, PSG polysomnography and no specification of type of botulinum toxin. Number of clinical case reports have described the appearance of bruxism as an adverse effect of medications. Generally speaking, mostly middle-aged women with a wide spectrum of psychiatric disorders developed awake and/or sleep bruxism few weeks after starting the medicament. Patients or bed partners reported that bruxism augmented or decreased in accordance with dose manipulation and that in some cases definitely disappeared with drug withdrawal. Second-generation antidepressants have been the more cited drugs prone to cause or exacerbate in some cases bruxism, further followed by antipsychotics or bupropion. The list of medicaments associated with bruxism is shown in Table 3. Regarding the clinical management, some authors have suggested to wait and see for 1 month because spontaneous remission may occur. If the problem persists, a reduction of dose or change of medication may alleviate or even resolve the problem, although a definitive cease might be expected with drug withdrawal. In those cases in which the psychiatric symptoms have been successfully improved with the current medication and no changes are planned, some authors have co-prescribed buspirone, tandospirone, or gabapentin, reporting a complete cease of bruxism. However, caution must be taken with the generalization of these findings, since case reports cannot establish cause-effect relationships and are susceptible to publication bias and overinterpretation. Based on these premises, costs and benefits of the drug manipulation should be considered individually and always performed by physicians. Moreover, polysomnographic and placebo-controlled studies evaluating the effects of antidepressants and other drugs on the occurrence of bruxism-like behavior require further research. Conclusion: in the absence of a causal treatment, the management of bruxism focuses to prevent progression of dental wear, reduce teeth grinding sounds, and improve muscle discomfort and mandibular dysfunction in the most severe cases. Counseling and behavioral strategies, splint therapy, medications, and contingent electrical stimulation have shown heterogeneous results in resolving the EMG events associated with sleep bruxism, and most of the RCT did not evaluate the effects on other symptoms such as pain or tooth wear progression. Long-term studies with a wide severity spectrum of sleep bruxism patients, and comparing the effect of different treatments should be performed to elucidate the importance of each intervention in the resolution of the signs and symptoms commonly referred by the patients. The choice of not treating bruxism must also be further explored, at least in asymptomatic patients with only mild dental wear. Even more must be done to successfully treat awake bruxism, in which RCTs are still lacking.